This is Eran Gorodeski with JACC Heart Failure. Happy to host today Dr. Milana Yusefbolskaya. Dr. Yusefbolskaya is an advanced heart failure and transplant cardiologist at New York Presbyterian, Columbia University Irving Medical Center in Manhattan, New York, where she also serves as the Associate Medical Director of the Mechanical Circulatory Support LVAD program. Milana is also an Associate Professor of Medicine at Columbia University. Milana, thank you so much for joining me, and thank you for publishing your work in JACC Heart Failure.
Thank you so much for having me. I'm very excited.
So by means of intro, I'm going to kick it off. Among about 7 million patients with heart failure in the United States, about 5% of them per year will advance to advanced heart failure. Advanced heart failure is defined by severe signs or symptoms of heart failure with minimal exertion or at rest, intolerance to guideline-directed medical therapy, or refractory symptoms despite maximally tolerated medical therapy. A portion of individuals with advanced heart failure may be candidates for life-saving therapy with either LVAD or transplant. Now, we do know that LVADs are underused among women with advanced heart failure, but the reasons for this remain unclear. And then further, we know that outcomes in women compared to men with LVADs remain uncertain. From what I understand, the purpose of your study was to examine differences in characteristics, adverse events, and survival between men and women. So can you tell us what you guys did in this study?
Sure. Thank you for the summary. So it's exactly right. The impetus to do the trial was that women have been traditionally and continue to be underrepresented in trial and remain most likely undertreated with advanced heart failure therapies, LVADs, and transplants. Momentum 3 trial is the largest trial in the history of MCS and gave us a wonderful platform to try to identify some of the potential impediments into implementing this life-saving therapy to women. What we know is, as I said, so roughly women represent 25% of patients in major trials. There's been a significant rise in destination therapy LVADs. However, the average age in the recent years compared to the prior years hasn't really changed, and it's been around mid-70s. So, we wanted to sort of investigate the outcomes among men and women, but also identify what are really the outcomes among older women and men who are getting LVADs. So we took the entire cohort of the trial and a continuous access protocol, which gave us roughly a little over 2,000 patients. 20% of them were women. And at first, we looked at the entire cohort, subdividing them into men and women. And the primary endpoint was survival-free of disabling stroke and requirement to replace the pump. And our secondary outcome was pure 2-year survival on the pump among men and women. And then we also explored some of the adverse events that occur on the LVAD. And we were pleased to see that the primary outcome was comparable at 2 years among men and women. We were pleased to see that the survival was comparable among men and women. But there were some differences in adverse events. And mainly women, on average, had higher rates of stroke, GI bleed, and infections. When we looked at the older cohort of patients, we were very happy to see that the primary outcome was comparable again. We were extremely happy to see that the survival was comparable. And also, interestingly, the adverse event profile was not statistically different between older men and women.
What about the younger women? When I read the paper, I was concerned to see that overall, as you mentioned, women had a higher rate of adverse events, and your paper reports that women had a 31% higher risk of GI bleeding, 71% higher risk of stroke, and a 14% higher risk of major infections. And I'm wondering, why do women have higher rates of these adverse events who get LVADs?
Yeah, unfortunately, this study couldn't really tell us why necessarily, but there were some statistically significant differences in baseline characteristics in the big cohort between men and women. Mainly, women were younger on average, and maybe clinically not, meaningfully enough, but women were 57 roughly, and men were in their 60s. Um, Women were more frequently overweight, and they had more tricuspid regurgitation, lower EGFR, again, maybe not clinically meaningfully so, but they were statistically significantly lower. They had smaller left ventricular size. So, so these are sort of baseline differences. However, they did have less comorbidities such as hypertension, atrial fibrillation, and prior strokes. It was great to see that they were treated comparably to men in terms of their heart failure medications, in terms of utilization of defibrillators and resynchronization therapies. Their
Fantastic.
intermax profiles were also comparable.
Got it. I'd like to ask you this. So when clinicians who take care of patients with advanced heart failure are talking to patients about LVAD therapy, and especially when they're talking to women who may need LVAD therapy, how should your study inform that conversation? What should clinicians be telling women who may need an LVAD as far as
Mm-hmm.
risks and outcomes?
Right. So I think that just to go back for a second to the age, right? What we did is, we compared men to women and we adjusted the outcomes by age. We looked at older women versus men, and there was no statistically significant difference. When you look at younger women versus younger men, there was a statistically significant difference in the side effect profile. However, we did not compare younger women and older women. So I just want to sort of make that clear. That's number one. Number two, I was incredibly reassured by the overall outcomes. And I think that number one, the therapy should be offered to all women. I think we should appropriately counsel patients in terms of potential higher side effect profile. And I think that the main adverse event is the stroke. Luckily, with the HeartMate 3, the rates are pretty low, and they really are mainly close to the operative procedure. If you look at the up to 2 years, the incidence of stroke between men and women are very comparable. So they really differ only in the sort of this early post-operative period. And, whether it's some of the risk factors that perhaps we can't really pick up on in the trial. For example, ventricular tachycardia, right, was a risk factor for stroke. Unfortunately, we don't have the data on preoperative ventricular tachycardia. We don't have the data on whether during implantation they required concomitant VT ablation that could have been a risk factor for stroke. So some of these nuances we couldn't quite elucidate. But, nonetheless, the risk is there. Ultimately, HeartMate 3 or LVAD therapy gives lives to patients, right? So if we continue to be skeptical about offering women this life-prolonging therapy, then survival without an LVAD or a transplant is extremely low, right? So I think that we have to counsel patients that this therapy will offer you longevity, and there are certain risks.
Fair enough. Fair enough. So in the context of knowing that women and men get the same survival benefit from LVADs, but that possibly women may have some higher risk of adverse events, including GI bleeding, risk of stroke and major infections, what are you guys doing at Columbia to try to reduce those risks?
Yeah, ARIS study was recently published, and I think that was another success for us in terms of mitigating some of the adverse events. So clearly, use of aspirin could probably be aborted in the majority of the patients. We hope that that will significantly reduce the risk of GI bleeding, especially in women and perhaps some of the younger women. With respect to infections, women did have a higher BMI, and that's a known risk factor for developing a major infection. And we're sort of being pretty aggressive in terms of counseling people on weight loss and some of the newer weight loss medications and potentially surgical optimization if it's appropriate.
Fantastic. Anything else that you want to add before we wrap up?
I think I think the main impetus and the main message from the paper should be that the therapy saves lives. And yes, there could be some adverse events. I think that the absolute numbers are quite small. And I think that we should absolutely offer this therapy to women. And I think we absolutely should offer this therapy to older women and counsel them appropriately.
Thank you so much.
I hope that this will just stimulate general cardiologists and heart failure practitioners to continue to advocate for women for this therapy.